Hello, everybody. I'd like to welcome you to this exciting breakout broadcast today, which is entitled Key Considerations to Ensure Long-Term Patients' Outcomes When Anatomy, Engineering, and Clinical Practice Come Together. I'm Professor Dave Smith. I'm an interventional cardiologist in Swansea, and I'd like to introduce you to a truly multidisciplinary panel of experts we have. Firstly, I'd like to introduce you to Professor Silvia Schiavano, who's a Professor of Bioengineering at University College London.
Hello, everyone.
Secondly, I'd like to introduce you to Dr. Luis Asmarats, who's an interventional cardiologist from Barcelona in Spain.
Hello.
And last but not least, I'd like to introduce you to Professor Andrew Cook, a Professor of Cardiac Morphology, also at University College London.
Hello, everyone.
So let's move to today's learning objectives for this broadcast. So we have three learning objectives. Firstly, I think we would all like to learn more about the cardiac morphology from a TAVI procedural perspective, but particularly related to younger patients with longer life expectancy. We're also going to understand what engineering, device modifications in our TAVI valves and our procedural refinements can translate into facilitating the lifetime management of patients undergoing TAVI. And lastly, we're going to share some clinical considerations to also make optimized outcomes for patients with longer life expectancy. I'd also like to remind you that this is an interactive broadcast, therefore you can contribute via the webpage to ask questions, and we'd invite those, and we'll try and make sure that we answer those by the end of today's broadcast. So now I'd like to hand over to Professor Andrew Cook, and we're going to have a live demonstration with a heart specimen with a focus on the TAVI procedure. Andrew, over to you.
Thanks very much, Dave, and welcome everybody. I'm here in the Cardiac Archive at UCL, and I'm going to use just a couple of specimens to start off with to show you the anatomy, cardiac anatomy, as Dave said, related to the TAVI procedure. So let's first of all move over to the specimen camera and show you really the importance of the central location of the aorta within the heart. So what you can see here is an adult heart, and in fact we've stripped away the epicardial surface of the heart so you can see the coronaries quite nicely in this case. And I'm going to turn it around so it would be positioned in the chest like this. I'm going to turn it around in anatomic position still, but as if we're looking now down into the aortic root. And what you can appreciate is that the aorta is a very central structure within the heart, and you see that certainly on all forms of imaging. So above the aorta, we have the pulmonary trunk. And there you can see the leaflets of the pulmonary valve. That, of course, is separated from the aorta by a muscular infundibulum. And you can see there, in fact, the two arterial roots are joined by the arterial ligament still, but I can put my probe between the pulmonary valve and the sinuses of the aortic valve, so the coronary sinuses of the aortic valve there. So on top we have the pulmonary trunk. Clearly we have the coronary arteries. The left coronary artery, as we'll see a little bit later, is the dominant vessel in this particular case. You can see a very large left main stem there and left circumflex. And then turning the heart around again, we've got a much smaller right coronary in this case, which is supplying the right ventricle. And then we've got a separate infundibular branch, which is not uncommon in normal anatomy. Now, more inferiorly, we have the non-coronary sinus, so that's more closely related to the plane of the atrial septum, which will be immediately below there. And then looking inside the heart, we can see the relationship to the mitral and the tricuspid valve. Now, as you know well, the mitral valve, the anterior leaflet of the mitral valve, is in direct continuity with the aortic valve. And we'll see that in just a moment in another sample. But it is separated. You can see there's the transverse sinus, the left atrium separating the aortic root there. But on the other side, we have the tricuspid valve. Again, very important valve these days in terms of intervention. three leaflets. You can see the anterosuperior leaflet, the inferior or mural leaflet, and then perhaps more importantly, the septal leaflet of the tricuspid valve. And at the anteroseptal commissure, we'd find the membranous component of the septum, which, as we'll see in the next heart, is closely related to the aortic outflow tract. And just below there, we'd have the position of the atrioventricular node. So there the AV node is within the right atrium and may seem distant to the aortic root. In fact, if you compress the aortic root, so if you put a surgical valve or a TAVI valve that's too large, and you compress these tissues towards the AV node, you can in fact disrupt flow to the AV node. So that's the general overview of the aortic root. Remember, very central in its structure. Let's move to a second sample. And this one, again, is an adult heart, a slightly larger heart, probably a heart similar in size to my own. It's similar to size to my hand there. We're looking from the right side. This is the right ventricle. But if I turn it around, then you'll see we're looking at the heart from behind. And I'm going to open it up to show you the opened up outflow tract and demonstrate some of the structures that are relevant to the TAVI procedure. Now I'll just zoom in slightly on the valve itself. What you'll appreciate, first of all, in terms of the aortic root, is that it extends from the sinotubular junction, this very faint ridge at the top of the sinuses, all the way to the basal part of the leaflets. So it extends all the way to the basal part of each of the sinuses, and the leaflets are contiguous with that. So that is the aortic root. Within there, we have the aortic valve, and you'll see the attachment of the aortic valve starts at the top of the sinus and then runs downwards, actually crosses the anatomic ventricular arterial junction and runs into the ventricle before it runs up again into the sinus, to the top of the sinus there. So we have this, this crescentic or semilunar attachment of the aortic valve leaflets, and then it's the leaflets themselves and that line of attachment that gives the aortic valve its true function. Now, that of course leaves triangles of tissue in between the leaflets. We call these the interleaflet triangles. And if we perforate those triangles, we'll actually go outside the heart into pericardial space. And so we risk tamponade. But let's just look at some of the other features relevant to the TAVI procedure. So as we're saying, the aortic valve is in continuity with the mitral valve, the anterior leaflet of the mitral valve. And here you can see the anterior leaflet extending between the two fibrous trigones. So the one that's closest to the ventricular septum is the right fibrous trigone. And then the one that's furthest away and more superior, as the heart would sit in the chest, is the left fibrous trigone. And you'll see that the region of fibrous continuity between the two valves, and therefore again relevant to TAVI, is mainly beneath the non-coronary sinus of the aorta. So this is the non-coronary sinus here. Now related to that and joining on to the right fibrous trigone, we have this region, which is the membranous component of the ventricular septum. In this heart, it's quite a large structure. It's not always as large as this in every person, but it's quite obvious that this is the membranous component of the septum. And sometimes the junction between the membranous component of the septum and the right fibrous trigone is described as being the central fibrous body of the heart. Now, why am I showing that to you? Well, it's relevant, of course, to the path of the left bundle branch and the conduction tissue. What we know is the left bundle branch will emerge from the septum approximately here, so at the junction of the membranous septum and the right fibrous trigone here. It is then variable in its course. So in some patients, it will run directly down onto the ventricular septum, basically into three fascicles, broad fascicles. But in some patients, it will run along underneath the membranous component of the septum before it then divides off. So there is some variability then in the proximity of the bundle, depending on the size of the membranous septum and on its traversing here and onto the crest of the septum before it divides off. And I think that'll be brought out perhaps in the following discussions. So that's on one side of the aortic valve. On the other side, of course, we've got to consider the coronary arteries. And we'll talk a little bit, no doubt, about coronary access a little bit later when we do the implant. But here you can see the origin of the right coronary artery in this heart, and that's not quite at the top of the sinutubular junction, but within the mid part of the sinus. And here's the orifice of the left coronary artery. From this point, they can take slightly different courses. So to access these, you may have to get a slightly different angle to get the wire perhaps into the coronary arteries. But there you can see the two coronary ostia. And clearly, if you're putting a TAVI valve in, you need to make sure that these are not obstructed by either the valve itself or the post in the valve or any other structure. So what I've got here, just to finish with, is a cage of a TAVI valve. Now this, in fact, is a Navitor valve, and you can see how that could fit nicely in the aortic root there. You can see that actually we need to be careful, quite careful. We're not too low down so that we don't obstruct and don't impinge on the left bundle branch. Remember the course I was describing to you there. And of course, make sure these posts align nicely, ideally, with the commissures of the aortic valve as it's being deployed. But you can see these nice wide open cells there, which potentially allow coronary re-access. So that's really all I'm going to show for the normal anatomy. Let me very briefly show you what it looks like in an abnormal valve. I don't want to give you the impression that the valve leaflets are all very nice and thin. We can have, of course, when we're intervening in patients, we're going to have a very abnormal valve. Now these leaflets, as you'll see, are very thickened and immobile. The brown material is calcium, and so they are very rigid. And you can see on the arterial side of the leaflets, you can see these nodules of calcium, potentially then, that could obstruct the coronary arteries. And in fact, the left coronary artery here, you can see how that nodule of calcium, if you pushed it back with a TAVI valve, may well obstruct the orifice of the left coronary artery. Now, given the fusion between the leaflets themselves could also be brought closer to the origin of the left bundle branch. So anatomically, that's very important in terms of the relationship of the valve and the conduction tissue. But I will stop there and I'll hand back to Dave for the rest of the presentations. Thank you.
Thanks very much, Andrew. That was a beautiful demonstration of certainly what as interventionists we do not get to see. As you beautifully highlighted, I think from an anatomical perspective, certainly when considering younger patients and their lifetime management, as you say, we have two obvious things from the anatomy to draw out. One is the risk of damaging the conducting system, as you've highlighted, between the non and the right coronary cusps. And I guess from our point of view, from an intervention point of view, we have to assess this by our CT imaging to best decide on that implant level. There's some data that is coming out about the height of the membranous septum. From an anatomical point of view, please correct me if I'm wrong, but clearly the membranous septum is not of consistent depth throughout its course. Could you just elaborate on that a little bit more? And you did touch on some of the variations that we see with both the membranous septum as well as the course of the left bundle.
Yeah, absolutely, Dave. You're absolutely right. The membranous septum is essentially the last part of the septum to close during development. And if you think of it a little bit like putty, it fills in any deficiencies that there are in the ventricular septum or the proximity of the ventricular septum to let's say the outflow tract cushions. And so we know that the membranous septum is a very variable size. If you look at a whole range of hearts or different patients, of course, it can vary in size quite dramatically. And the example I showed was quite a large membranous septum. And so measuring the height of the membranous septum, I think, has been shown or is being looked at, isn't it, in terms of proximity to the left bundle branch. But as you say, then you've got to think about the course of the left bundle as it runs across the septum. So it isn't immediately diving downwards towards the apex. And you've also got to think about that course as it can vary and go across the septum. There's no way, unfortunately, there's no way of seeing it, and certainly no way of you seeing that on CT, unfortunately. As you saw, even with the hearts or when you're performing surgery, you can't see the conduction tissue.
No, absolutely. And I guess the second point that you highlighted was coronary access. And I know that we will move on to talk about that at the end of this broadcast when we do a live simulation. But I guess just to tease out a few more points about that for people in the audience listening, I guess that we've been very easily attuned to the height of the coronaries relative to our, if you like, the basal plane that we measure on CT. But also there's some other consideration to take into account with regard to the width and the height of the sinuses as well. Now we see on the CT scans that there's significant variability, but clearly we need to be taking into account all three of these attributes: height of sinus, height of coronary, as well as the width of the sinus. And I wondered from an anatomical point of view whether you could make further comment on that.
Yeah, I mean, and there is a lot of variability. There is quite a bit of variability in the width of the sinus. So the size of each of the leaflets is a known, is a known variable amongst even normal valves, let alone aortic stenotic valves. So yeah, I think it is really important as the coronary moves closer to the edge of the sinus, then of course there's a greater risk that the leaflet may overlap the coronary artery. In the normal heart, partly because of the way the leaflets are attached to the base of the sinus, and that part curves under, that there'll be the leaflet, when it's pushed back into the sinus, normally will run about 2/3 to the height of the sinus. So although we might think it being full height going up to the sinotubular junction, it doesn't in the normal heart. So that will help in some ways, but I agree entirely that looking at the position in terms of the width of the sinus is very important too.
Brilliant. Thank you, Andrew. That's been absolutely fantastic. We'll come back to you a little bit later when we do the live simulation, which will further emphasize a number of these points. I'd like to hand over now to Silvia Schiavano and really talking about, from an engineering perspective, enhancements in TAVI engineering and how this may impact upon clinical outcomes. Silvia, over to you.
Great, thanks, Steve. Thanks, Dave. And in this presentation, I will try to provide a brief overview of the engineering requirements and the latest announcements in TAVI technology. In terms of requirements, these are regulated by standards, and what the engineer needs to do is really to try and balance between several different requirements in terms of device design that sometimes are contradictory. And unfortunately, in terms of TAVI, the balance really looks more like this, because it's an incredibly complex problem with a complex system where really we have a high correlation between the anatomy and the function. There are both structural problems and hemodynamics problems. And what we really want to achieve is the optimal device implantation site interaction for each individual patient. So it's not surprising really that in the past 20 years, several solutions have been proposed to try and tackle most of the complications that still remain with transcatheter aortic valve implantation. And indeed, even in the past 2 to 3 years, new technologies have come into market. And for example, the Navito from Abbott has really tried to improve on all these issues related to TAVI. When I talk about contradictory requirements, I will go now through this radial force example, because it's quite obvious that what we want is really high radial force to make sure that we can guarantee a good stability of the device in situ, that we open the most specific valves, also achieving a circular cross-section for the optimal valve functioning, and also to try and reduce paravalvular leak. But at the same time, we want really low radial forces because we don't want to injure the tissue. We want to avoid compression of the conduction system, as Andrew also mentioned, and we want to guarantee good flexibility during the delivery of the device. So how can an engineer really achieve the good balance in this example? Well, first of all, we really work with the device design, and in particular, we can work with both the material properties and the geometry, the shape of the stent, to tune the radial force. For example, during the delivery, if we follow this curve between the force and the diameter, we can really play with the material properties in the case of self-expandable stent with nitinol, or with the geometry of the stent cells or the thickness of the structure, to make sure that we have a suitable force that is applied to the implantation site. And indeed, we need to keep in mind the implantation site, because this is really what drives the radial force that you want to achieve with the device. And again, for the implantation site, we look at both material properties and anatomies, because we know that, for example, in the elderly patients, we have stiffer implantation sites, which is not probably the case in the more young population. And at the same time, in the elderly, where we have loss of calcification, we know that the cross-section, so the geometry where we're going to implant the stent, is probably not circular in terms of shape, often with very weird anatomies as well. So in order to make sure that we achieve the best, we need to really work and optimize the interactions between these, so the device on one side and the implantation side. In terms of the diameter, to make sure that it's the optimal balance between the stent and the implantation site, final nominal working diameter. We need to make sure that we have good contacts along the length of the device and the cross-sections to avoid this dislodgement due to the diastolic pressure gradient that is impinging on the valve, the closed valve, and the area of the valve itself. So depending from these parameters. And again, how do we do that in terms of engineering? Well, we try and find the right balance. So when the diameter of the self-expandable stent is increasing, we reach to the point where we have contact with the artery, and then we want to make sure that we increase slightly more the diameter to avoid dislodgement, while at the same time not too much, to make sure that we avoid injury to the implantation site. And therefore, we need to make sure as engineers that we work in that specific range of the curve in terms of forces. And what Navitor has done is really trying to change and tune the way we move in terms of the forces along different ranges of diameters. So we can see that you can maintain constant radial forces despite we work at different diameters without moving along the curve, but really shifting the curve itself by tuning the material properties. And you can see an effect this on the initial, so the proximal portion of the stent with these different diameters here. We also look at contacts, and you can see in the first picture where clearly there is not a good position of the device into the implantation site. And apart from the issues in terms of hemodynamics, you can see that with Navitor, achieving a full circumferential opening along the entire cross-section guarantees a better distribution of the radial forces in this direction. If we look at the valve itself, we want to have a flexible thin leaflet to guarantee good dynamics. We want to have an optimal closure at all delivery cross-section shapes. So even if the cross-section is not circular at all, like in the pictures achieved by Navitor, but we also need to work in terms of the geometry of the leaflets and the combination stent and leaflets to guarantee that we have a good geometrical orifice area that has a huge effect on the effective orifice area and potentially on the gradient across the valve. And you can see here in this fluid dynamics study where you can really see the effect that the different shapes in terms of geometry of the valve can have on the hemodynamics itself. But clearly, we also want to guarantee durability of the valve. So thin leaflets present a problem in this direction. So we need to work towards better leaflet properties to guarantee this in the long term. I will just touch base very quickly on the hemodynamics as well, in particular on paravalvular leakage in this slide, where you can see the retrospective treatment of this problem was achieved in the past with plugs, but really in terms of engineering, the technology has changed dramatically with prospective treatment of this potential problem by the insertion of these cuffs that work basically as a sail to prevent the issue with paravalvular leakage. Another point that has already been discussed before is coronary flow. This can be guaranteed potentially by the use of the intra-annular positions of the valve leaflets itself, so that they don't occupy the space around the sinuses. But even if in the case of longer stents that guarantee a better stability, still coronary access and coronary flow can be guaranteed if the stent's design is done in a good way, where you have enough space amongst the cells to be able to access the coronaries, like is shown in the last picture. And finally, just want to mention briefly that there is an intrinsic problem with TAVI, which is related to stagnation, because the native leaflets remain in place and therefore occupy the space in the sinuses. This unfortunately has an effect on the circulations within the sinuses. There is less washout and therefore more issues related to thrombus formations. So just to conclude, I hope I gave you a very brief overview of really the engineering challenges, but also all the latest advancements that have been achieved so far with, for example, the Navito technique. And I will pass the word then to the next speaker, where you will see what these engineering solutions and choices have had as an impact in the clinical outcomes for patients. Thank you.
Brilliant. Thanks very much, Sylvia. It's really good to have an engineering perspective on this. So I'm going to hand straight over to Dr. Luis Asmarats now, who's really going to just talk us through how these anatomical and engineering enhancements aid the clinical management of patients with severe aortic stenosis. Luis, over to you.
Thank you, Dave. Let's discuss the TAVI patient long-term management and the first implantation and future implications. So the main iterations of Navitor have already been discussed, but it is a self-expanding intraannular valve with large cell design, and the novelties are the incorporation of an outer cuff to reinforce the sealing and increase radial force. In this presentation, I will focus on some of the aspects to consider for the lifetime management of TAVI patients, and mainly I will focus on PVL, coronary access, and patient prosthesis mismatch. So this first case is an 87-year-old woman with a severe valve calcification and a Gaston score of nearly 4,000. With, as you can see, a very bulky and large LVOT calcification. So this kind of high-risk anatomies in which we must balance between risk of annular rupture or a potential PVL. So we decided to go with Navitor. It was a real AC test for Navitor. We pre-dilated with a 20-millimeter balloon with a good expansion, and we did a slightly low implant in case we needed to post-dilate with a very good result, and actually we didn't need to post-dilate. So we can see in the echo the final result with no PVL at all. So this case highlights the huge improvement of this new generation valve in terms of better sealing and increased radial force, especially for the two smaller valves, the 23 and 25. So the second scenario I want to talk about is patients with coronary artery disease or at risk of coronary obstruction. So what features we will ask to have a device, to a valve for those patients? So mostly, for instance, or a short stent frame valve, that is a balloon expandable valve, or in case of taller valves, valves with large cell design and intraannular design. So I will show a couple of examples. This first example is a quite challenging case that we did recently. This was a patient that was referred for TAVR, but she had undergone an ostial right coronary artery PCI in another center some weeks before the procedure. But you can see in the final angio how the stent is protruding at least 50% in the aorta. So even though the height of the right coronary artery was about 10 millimeters, we were quite concerned about a potential crash or the configuration of the stent because the sinus of Valsalva were very narrow, were only 24. So we decided to protect this coronary with a guide wire and a balloon. We pre-dilated, was a very fibrotic valve. The implant result was very good, but you can see in this slide how, despite this floating stent in the aorta, we could say recannulation of the artery, of the coronary artery, was quite relatively easy, and we could post-dilate, and we got a good final result. The second coronary access or case I will show, this is a valve procedure with risk of left main obstruction. We decided to protect with a stent. So this is a strategy that we are using more and more, that has already been described. But in patients, when we don't have a complete coronary occlusion and the patient is still stable, we get a second access, and we advance a second guiding catheter inside the implanted TAVR. To provide what we believe is a kind of more physiological stenting. We avoid stent compression and would facilitate a potential recannulation in the future. And so far, we didn't have any issue using this technique with this valve. And the third scenario I want to mention is patient prosthesis mismatch. It's always challenging for TAVR when we face patients with small annuli, with valve-in-valve. And we have to bear in mind the design of the valves. Navitor has a cylindrical, has already been said, but is a non-tapered design. So the inflow and the outflow is the same. And this favors good hemodynamics in general. As we can see in this native small annulus, a perimeter of nearly 60 with a 23 millimeter valve, we got a result, a gradient below 10. This is a valve-in-valve procedure, a degenerated mitral flow, small mitral flow, 21 millimeters. In those cases, in general, we tend to do a direct implantation and with a systematic post-dilatation with NC balloons or cracking in case of small surgical annulus of 21 or less, as this case. So that's what we did. We implanted direct implantation of a 23 millimeter Navitor, and we did cracking with a 20 millimeter NC balloon. That is 3 millimeters more than the inner diameter. And as you can see, the final gradient was really, really low. And this is my last case. This is a TAVI degeneration. This is always challenging cases, but we will see this more and more, more commonly. So this was a Sapien XT that was implanted 10 years ago in an 80-year-old man. And now he had the degeneration with a very critical stenosis. He had severe chronic kidney disease and severe vasculopathy. So we decided to go transcarotid with no contrast, just TEE guided. So in this case, we pre-dilated because stenosis was very critical with a mean gradient of nearly 90. We aligned the inflow of the Navitor over the inflow of the Sapien, and we got a significant gradient reduction. And we can see there was no residual PVL, and if we could even check the coronary patency through TEE, as you can see on the right of the screen, with no need of dye injection. Yeah, so just to conclude, a study expands to younger patients and low-risk patients. A younger age will demand a very careful device selection and better evidence in terms of hemodynamic performance, valve durability, coronary reactions, and preservation of options for safe reinterventions if needed in the future. And obviously, if we want to guarantee good long-term outcomes, we must optimize as much as possible our procedural outcomes. Thank you.
A brilliant talk. Thank you, Luis. Some very difficult cases in there, but some very important points for these younger patients and their lifetime management. We've got a couple of excellent questions for each of you, Sylvia and Luis. I'm going to start with you, Sylvia, if I may. One of the questions that the audience have asked us is there any engineering explanation for the so-called pop-up or embolization phenomenon that can be seen with self-expanding valves when they clearly don't stay in the intended location of the aortic annulus?
Yes, I don't think it's been quite yet to figure it out in details, but I think there is a fundamental difference in the way a balloon expandable stent is designed versus a self-expandable. So the balloon expandable stent achieves the final diameter with the drive of the balloon, and this is the diameter where it will work at. while the self-expandable stent has a radial force that continues and potentially would continue to expand all the way to the final open of the stent without interaction with the device. So I think it's that balance in the moment when it's delivered where it achieves the perfect nominal diameter, balancing the hoop force, so the strength force that the implantation sites has on the stent itself and the outward radial force that the stent is trying to impress onto the implantation site. So it's the moment where between the geometrical interference between the two and the achievement of the radial force balance that potentially there is this tiny movement. But I think more studies are probably required in terms of trying to characterize in which implantation sites this happens. So if it's driven more by the geometrical interference or more potentially by an adjustment in terms of the radial forces themselves.
Thank you very much. Luis, I've got a question for you from the audience as well. I think you've probably already touched on this with your patient prosthesis mismatch to a degree, but the question is, what are the differences or advantages of this valve versus the SAPIEN 3 balloon expandable valve?
Actually, this is a personal opinion, but in small annuli, the feeling is that balloon expandable valves in small annuli, 20 millimeter SAPIEN, for instance, in general tends to leave higher gradients, to be more restrictive than a 23 self-expanding valve, for instance, Navidor. No? Why? My feeling is that probably this Navidor or Portico Navidor is a an intraannular valve, but not strictly intraannular, since the leaflets are mounted are at 7 millimeters from the inflow. So this could be like a kind of intermediate design that could explain why we in general we get lower gradients in larger areas than with other intraannular valves.
And as you've highlighted, I guess that's very important for the long-term durability potentially of these valves in patients with a longer life expectancy. Okay, thank you very much, both of you, for those excellent talks. Andrew, I'm going to hand back to you to show us how you should really put these valves in. So over to you to simulate a TAVI valve insertion inside a heart specimen. Over to you.
Thanks again, Dave. Yes, we're going to attempt a TAVI implant in these heart specimens. Actually, we're going to start off with the one that I showed you last, and then we're going to move to the first specimen. So we're going to show you in the short axis how it's deploying, and what we will do is stop as we go through. So we'll stop halfway through and just ask for comments from Luis and anybody else, of course, and then we'll carry on with the deployment. So this will all happen in 4 minutes now, but we will, let's move over to the camera and first of all, show you the position, the optimal position then of, I have Igram helping me in the lab here, optimal position then with respect to deployment first of all. So in a long axis view, if you like, of the left ventricle. So of course, you may be coming from the descending aorta, femoral access, or you may be coming from radial access in some patients. But essentially, the compression or the direction of the cone that you can see in the end should be towards the left ventricle, of course, should be a few millimeters below the basal part of the sinuses, so the basal part of the leaflets. So a few millimeters, a couple of millimeters below. And the tension, of course, will be pushing on this component here. So between the right generally and the non-coronary sinus, but that will depend on the degree of fusion of the valve. And then, of course, you'll gradually deploy and unsheath the device, as you can see here. And we'll stop just at that point and show you perhaps the cells beginning to deploy just there. And hopefully they'll deploy in an even fashion. But of course, remember, the tension is against the septum, and so that may affect the actual expansion of each of those cells. So if we just retract that once again, as we can do in these samples, if we can retract that into the system, and then we'll move to the second heart sample. And we're going to show you this from above. So I am estimating where the end of the sheath is, of course, and I'm going to try and hold that within the left ventricle. But again, let's go from above. So let's simulate a sort of femoral access, so between the right and the non. We're entering here. I'm just going to zoom in a little bit so you can see that more clearly. Trying to estimate before we start that is just below the base of the leaflets, and I think it is there. We're going to begin to deploy. So start to deploy. Hopefully I'm not too low there. We will see. And as we come upwards, we're going to stop just before the point of no return. There you can see one of the posts, in fact. So you can see one of the posts of the valve. And in fact, just by chance, and this is purely by chance, we've managed to align it with the commissure there between the left coronary and the non-coronary leaflet. So hopefully, as we deploy, the post will be in alignment with the commissures. And I don't know if Lewis, if you want to make any comments on that, or if you'd like us to reposition it in any way. Are we too low? Are we too high?
Actually, I think it looks an amazing implant. Difficult to tell the implantation since we are from the aortic size, but yes. Actually the commissure alignment is perfect, as you mentioned, so almost sure will be no coronary overlap. No? So
okay.
you can
right.
go on.
Thank you, Lewis. Yeah, okay, well, let's carry on. And we just hit the point of no return there on the system. And now we're going to deploy the valve. I'm going to try and, remember, this is a simulation. So deploy the valve. Valves are now deployed. You can see there that we've got, yes, quite a nice implant, I think. So just to reiterate, we have the nice open cells of the device. We have the leaflets of the device, which are able to close together in the center. So as we'd expect for a normal aortic valve there. And then just look at the coronary arteries. So remember, we had a big left main stem, which is here. And actually, if I turn the heart around, you can see that we can quite easily access that through the lower part of this cell in this particular case. So we seem to have good access there to the left coronary artery. The valve itself is below the level of the coronary. We'd have assessed that, of course, by CT previously. And then just turning the heart around, the right coronary, that's a little bit difficult to see because it's a smaller vessel, but that's the opening of the right coronary. So I come this side, there you can see the opening of the right coronary artery. And again, that's at the top of an adjacent cell. But again, I think you can see you can get good access to the right coronary artery. Is there anything else you'd like me to show briefly, Lewis, before we move on? How do you think it looks?
I think it looks very good. I don't know if you can see the apposition, the expansion which is very good. The apposition to the rest of the valve.
Yes. Now, of course, good, yeah? I've actually deployed this, of course, in a normal aortic valve. We try not to damage the other, the abnormal valves. But I guess you're referring to this. Is there any space beneath the leaflets? Now, I can't show you from underneath. But is there any space between the valve and the leaflets itself? Perhaps a little bit there, but we could, perhaps with a bit of adjustment, we could easily close that up, I think. And of course, I'm not looking at the outside of the valve, which is, if this is navitor, of course, which will be where the seal is. So remember, that's on the outside of the stent. And you perhaps can see the base there of you might actually be able to see the base of the cuff there, just at the bottom. But essentially, yes, with a calcific valve, we might expect the paravalvular leak to occur really at the commissures in general. That it happens at the commissures, and so it's this region really. It would be looking for paravalvular leak. Yeah.
Excellent.
Thank you, Lewis, and thank you, Dave. We'll hand back to you.
Thanks, Andrew. I think you're putting us all to shame. I think I should learn anatomy and you should put in more of these valves. But a beautiful demonstration of the surrounding anatomy. And again, you've highlighted beautifully initially conducting system problems potentially, and also there you've highlighted beautifully the access to the coronary arteries. One of the questions from the chat is what coronary catheters do you use to re-access the coronary arteries after a TAVI procedure with a Navitor valve? And the honest answer is you use your conventional diagnostic Judkins shapes to access the coronary arteries, and certainly in my experience this is a very easy valve with which you can re-access coronary arteries after a TAVI implant. So I'd like to sort of really round things up. I'd love to say we could chat for longer, but we're running to the end of this broadcast. And certainly I think firstly, I'd like to thank the panel of experts. Sylvia, I'd like to thank you firstly.
Thank you, Dave, and thank you, everybody. Goodbye.
Luis, again, I'd like to thank you for your excellent talk and your insights, particularly with Andrew's last demonstration there as well.
Thank you very much, Dave.
And Andrew, lastly, I'd like to thank you. It's a privilege, I think, to see the anatomy demonstrated so beautifully, and I think hopefully for the audience, again, quite a unique opportunity for them. So thank you very much.
Thank you, Dave. It's a pleasure. Yep, thank you as always.
So I think we've looked at our learning objectives. We've certainly looked at the morphology in great detail as demonstrated by Andrew. From Sylvia, we've learned how engineering modifications are ongoing. And we've seen from Luis's talk, as well as his narration of Andrew's simulation case there, how we as clinicians need to combine these aspects for our patients. So really there's a critical interdependency, I would argue, between morphology, engineering innovation, and our clinical translation of that into our procedures to benefit the long-term outcomes for our patients. So I'd like to thank you all for listening for this broadcast. I'd like to signpost you as well as back to the main meeting, but it's 7 o'clock Central European Time, 6 p.m. UK time. There will be a live demonstration from Rotterdam from Professor Nicholas van Meegem, showing you a Navitor valve being implanted in a live case, and therefore I'd look out for that. But otherwise, thank you for listening today and enjoy the rest of the course. Thank you very much.